Okay, next up is mitral regurg. So the question stem will include patients, well, first of all, you can get it from degenerative changes. Patients might have infective endocarditis. So endocarditis causes regurgitant lesions. And so if the question stem includes patient with endocarditis, think about TR, MR, AR. You can get secondary MR from ischemia or dilated cardiomyopathy, so that's also known as functional MR. Have you heard of that? Where basically the valve itself is not problematic, but if the LV dilates out, that starts to dilate the annular ring of the valve, and basically the leaflets won't touch each other when they can't co-op properly. So you get functional MR as a result. Your exam will include a holosystolic murmur over the apex with radiation to the axilla, bolded because if you see that, it's MR, period. You might also hear an S3 gallop with MR. Why? So S3 gallop occurs in volume overloaded states, and so if you have a bunch of regurgitant volume going back to your LA, when it goes back to the LV, you have this big bolus of blood dumping into the LV, and it's going to make that S3 sound when it enters the left ventricle. So that can be a clue that you're dealing with mitral regurg. And then, of course, as we talked about, afterload. So increasing afterload is going to increase blood flow through that valve, and it's going to increase the murmur. Okay, so there's pretty limited medical management for MR. Really, your only option is surgical repair when it's severe enough, and then your options are kind of repair, clip, replacement, and this is fairly new, probably too nuanced for this lecture and for this exam.